Hello, my name is Gerald Schmidt. I'm the nutritional support pharmacist at UF Health in Jacksonville, Florida. Today's topic is one in a series of subjects brought to you by Channel 1 On Demand Nutrition Education. Today we're looking at fluid and electrolyte management in parenteral nutrition solutions. When managing fluids and electrolytes, there are several basic principles that make management simpler. It starts with assessing the fluid status or needs of the patient. Next, determine if the electrolyte abnormality is acute or chronic. Treat acute problems acutely or with a pelvis infusion. Treat chronic problems chronically with maintenance fluids. Finally, treat critical values acutely. Once the critical value is corrected, go back and determine if the maintenance needs to be adjusted or not. When determining fluid status, start with intake and output and signs and symptoms. If the patient is hypovolemic, the patient may exhibit signs and symptoms such as hypernatremia, elevated blood urine nitrogen to serum creatinine ratio, acute weight loss, worse skin turgor, tachycardia, or a negative fluid balance. Conditions that may contribute to hypovolemia include severe diarrhea, gastrointestinal losses, diuretics, and inadequate fluid intake. Patients that are hypervolemic may exhibit signs and symptoms such as hyponatremia, peripheral edema, pulmonary edema, increasing weight, or a positive fluid balance. Disease states that may contribute to hypervolemia include congestive heart failure, liver failure with ascites, and renal failure. The Holiday-Seeger equation is utilized to calculate fluid requirements in adult patients. As the body ages, total body water decreases, so fluid requirements have been further adjusted in older patients. Recommendations have been further refined to 35 mL per kilo for patients from 18 to 55 years of age, 30 mL per kilo from 56 to 75 years of age, and dropped to about 25 mL per kilo for patients greater than 75 years of age. Adjustments in weight must also be made for patients that are greater than 125% ideal body weight. Adjusting the body weight can be used in all patients for simplicity's sake, or if your computer systems cannot differentiate between patients that are greater or less than 125% ideal body weight. The equation for ideal body weight is adjusted weight minus ideal weight times 0.25 plus ideal body weight. Now let's compare requirements calculated using the adjusted body weight and an actual body weight in a 62-year-old male that is 71 inches tall and weighs 134 kilos. So 134 minus ideal weight, 75.3, times 0.25 plus 75.3, the ideal body weight, gives us an adjusted weight of 90 kilos. Going to take 134 kilos times 30 mL per kilo, that gives us 4,020 mLs, which could lead to fluid overload. In the adjusted weight with 90 kilos at 30 mL per kilo, we get 2,700 mLs, which is a much more reasonable fluid volume. Fluid goals are not necessarily our fluid requirements. Environmental studies have shown several factors that affect fluids by as much as 20%. These factors include ambient temperature, activity, exposure to sun, and humidity. In fluid restriction studies in heart failure patients giving 80% of fluid requirements compared to normal fluid requirements had better outcomes. Based on these studies and the facts that patients frequently receive other fluids in addition to parenteral nutrition, starting with 80% of our fluid requirements is reasonable. So if we're starting with 80% of fluid requirements, giving 30 mL per kilo, this calculates to 24 mL per kilo, or their weight is their rate. Remember, this is just a starting volume. If the patient's dehydrated, replace the fluid deficit outside the parenteral nutrition solution. If the patient is fluid overloaded or the patient is elderly, the parenteral nutrition solution may need to be reduced further than 24 mL per kilo. On subsequent days, adjust the fluid volume up or down by 20% based on fluid status. Now that we've determined how much fluid to give, we need to determine the amounts of electrolytes that need to be added to the parenteral nutrition solution. The adult electrolyte algorithm is for the adjustment of maintenance electrolytes only. The numbers in the boxes are the starting doses of the electrolytes in milliequivalents or millimoles per kilo, unless the serum levels are high. Differences in specific electrolytes will be addressed separately in the next few slides. When dealing with sodium, first determine the fluid status of the patient. Hyponatremia is typically a result of fluid overload or inadequate sodium intake versus excessive sodium excretion. If the patient is fluid overloaded and hyponatremic, adjust the fluid volume, not the sodium. If the patient is euvolemic and hyponatremic, adjust the sodium. Hypernatremia is typically a result of dehydration or excessive sodium intake versus inadequate sodium excretion. If the patient is dehydrated and hypernatremic, adjust the fluid volume, not the sodium. If the patient is euvolemic and hypernatremic, adjust the sodium. On day 1 or subsequent days, if the reason for the hyponatremia or hypernatremia is due to a fluid imbalance, adjust the fluid volumes, not the sodium. Otherwise, start with the number in the box or the amount from the previous day. In this example, 1.1 milliequivalent per kilo adjusted body weight. If the serum value is high, follow the arrow up 1 step. If the serum value is low, follow the arrow down 1 step. For potassium, magnesium, and phosphorus, the process is the same. I will be using potassium as the example. We will start with the number in the box, 1 milliequivalent per kilo. If the serum creatinine is elevated above 1.5 milligram per deciliter, or the serum level is elevated, follow the arrow up 1 step, which will be 0.5 milliequivalents per kilo adjusted body weight. If the serum creatinine is greater than 1.5 milligram per deciliter and the serum level is elevated, follow the arrow up 2 steps, which would be 0 milliequivalents per kilo. The adjustment for renal failure is only done initially. Do not adjust the potassium, phosphate, or magnesium for the first 3 days unless serum values are elevated. Hypokalemia, hypophosphatemia, or hypomagnesemia seen in the first 3 days of therapy are usually due to refeeding and should be replaced outside the parenteral nutrition solution. On subsequent days, after day 3, the process for potassium, phosphate, and magnesium are the same. Start with the amount added the day before, in this case 1 milliequivalent per kilo. If the serum value is high, follow the arrow up 1 step. If the serum value is low, follow the arrow down 1 step. For calcium, on day 1 or subsequent days, start with the number in the box or the amount from the previous day. If the corrected serum calcium value is high or the ionized calcium value is high, follow the arrow up 1 step. If the corrected serum calcium value is low or the ionized calcium value is low, follow the arrow down 1 step. Now that we've determined the amount of electrolytes to be added to the parenteral nutrition solution, we need to balance the electrolytes or convert the cations and anions to salts. There are up to 7 cations and anions that may be included in parenteral nutrition solutions. Magnesium and calcium are not included in balancing of the electrolyte solution because magnesium is usually added as magnesium sulfate and calcium is usually added as calcium gluconate. This leaves sodium and potassium as the cations and chloride, acetate, and phosphate as the anions. Balancing chloride and acetate is easier when ordering electrolytes by cations and anions. The prescriber chooses the most appropriate chloride-acetate ratio based on the serum chloride and serum bicarbonate. The computer then calculates the salts based on the following common chloride-acetate ratios. All chloride, a 1:2 ratio of chloride to acetate, a 1:1 ratio of chloride to acetate, a 1:2 ratio of chloride to acetate, or all acetate. However, it's much more complicated when converting cations and anions to salts. There are 6 salt forms that may be used: sodium chloride, sodium acetate, sodium phosphate, potassium chloride, potassium acetate, and potassium phosphate. Always start with phosphate since sodium phosphate and potassium phosphate are the only salts that do not have a 1:1 ratio between the cations and anions. There are approximately 1.33 milliequivalents of sodium for every 1 millimole of phosphate and sodium phosphate. So the cations that need to be balanced with chloride and acetate are equal to the sodium plus the potassium minus the phosphate times 1.33. There are approximately 1.4 milliequivalents of potassium for every 1 millimole of phosphate and sodium phosphate. And the equation is cations to balance is equal to the chloride, or the sodium plus the potassium minus the phosphate times 1.47. In the following example, we're starting with 90 milliequivalents of sodium and 90 milliequivalents of potassium and 18 millimoles of phosphate. You can use either sodium phosphate or potassium phosphate. In this case, I'm using sodium phosphate. And we have a 1:1 ratio of chloride to acetate. So when we take 90 milliequivalents of sodium plus 90 milliequivalents of potassium minus 18 millimoles of phosphate times 1.33, that gives us 156 milliequivalents of chloride and acetate, split between equally gives us 78 milliequivalents of chloride and 78 milliequivalents of acetate. These are our starting amounts. First step was to add the sodium phosphate, which gave us 18 millimoles of phosphate and 24 milliequivalents of sodium. So we subtracted the 24 milliequivalents from the 90 milliequivalents, which leaves us with 66 milliequivalents of sodium and no phosphate. In the next step, it doesn't matter which salts you start with because the rest of the anions and cations all have a 1-to-1 ratio. I started with potassium chloride, 78 milliequivalents. We have 90 milliequivalents of potassium and 78 milliequivalents of acetate. Therefore, the acetate was the limiting factor. So when I add the 78 milliequivalents of potassium acetate, I have 12 milliequivalents of potassium. The next step I chose was sodium acetate, 66 milliequivalents. There are 66 milliequivalents of sodium and 78 milliequivalents of acetate. So this left 12 milliequivalents of acetate. The next step was to add potassium acetate, 12 milliequivalents. So this leaves all of the electrolytes balanced. Step 5 would be to add the desired amount of magnesium as magnesium sulfate and the desired amount of calcium as calcium gluconate. This concludes the Channel 1 on-demand nutrition education topic, fluids and electrolytes, and parental nutrition solutions. Thank you.